Good morning, everybody. I'm Jaci. I'm going to be introducing Dr. Jaci VanHeest. She's an associate professor of the educational psychology in the Neig School of Education with a joint appointment in the Department of Kinesiology at the University of Connecticut. She serves as a faculty director of the Public Health Learning Community at the university. Her research specialization is in the area of endocrine control, of body weight, and metabolism. Prior to her tenure at UConn, Dr. VanHeest was the exercise physiologist for the USA Swimming, researching factors impacting both on developmental and Olympic level athletes. Beyond her research publications, Dr. VanHeest has published numerous chapters and lay articles in the developing athlete. Dr. VanHeest utilizes basic and applied science techniques in her work with overweight children and competitive athletes. Today, we welcome Dr. VanHeest and the information she'll be providing us about obesity intervention strategies for both children and adults. Dr. VanHeest, thank you for being here.
First of all, thank you for the introduction. I certainly appreciate being introduced by someone with such a nice name. As well, I always find it interesting when you follow a speaker that is eloquent and who is speaking about something that's cutting edge and novel, to then begin to talk to you about something you've all heard about a million times. And so what I'd like to do is have us think a little bit differently about this notion. And so what I'd like to start with, let's use this maybe, or not. Are we stuck? We're stuck. Yep. We're stuck. We're still stuck.
Just use the arrows down here.
Second here. Oh,
That should do it.
perfect.
It might
Okay.
be now.
Let's see. Albert Einstein said, "We cannot solve our problems with the same thinking we used to create them." So today I'd like us to think about this concept of obesity and strategies to manage obesity in a different sort of way. I'd also like us to start out by being honest about one thing, that if we are typical humans, we more than likely have a bias toward obesity and weight. And we need to use our filter and understand that filter exists as we progress and think about things today. There are many ways to classify obesity. Most of you have seen a number of approaches to classify obesity. The one that is, in essence, sort of the gold standard or the most common would be body mass index. If you take a look at body mass index, we know from our understanding of body mass index is that it's really a relationship between a person's height and a person's weight, and that there are a number of ways for us to look at body mass index in individuals and categorize them in levels of weight excess. That being those who have a BMI greater than 25 are considered overweight, greater than 30 are considered obese, and then we see the various classifications of obesity as you see on the right. Please remember that this is for adults. Children have the relationship of their BMI to age and gender when we assess their obesity or overweight status. One thing I'd like to note at this point is that an individual can be metabolically healthy and be considered obese. So they can have a BMI over 30, and they are known as having the metabolically healthy obese phenotype. Now, this has been in the lay press substantially, and we have this sort of fit-fat notion. Is it okay to be fit and fat? And it's something that we've talked about, that the media has grabbed onto. And what's interesting about this is that as we've looked at this data over time, one of the things that has becoming quite apparent is that this is not a benign condition. What I mean by that is that often what you will see, unless the individual is capable of reducing some of that weight, or in essence body fatness, that individual will often have the capacity to transition into having comorbidities. And we will see again that those comorbidities frequently begin with cardiorespiratory elements and or with issues surrounding the control of glucose. And so we see pre-diabetes play into this. We often will notice that blood pressure may be one of the things that's an early indicator. The reason I'm bringing this up is that these individuals, even though I think in our heart as sort of exercise physiologists, we often think that they're in a really good place because they're doing certain things, and it is a good place. It's a great starting point. It's important for us to pay attention to them medically and clinically as we progress, and not just let that seem to be the place that they stay. Now, you've seen a million slides on this, and as a person who is interested in bioenergetics, I am compelled. I think I am almost demanded to show you these, and so if you've seen them before, I apologize. But it also makes the point that we have a lot of work to do. This is a scenario in not only our country, but around the world that exists, continues to exist, and we are making dents here and there. But what you'll notice is that this is prevalence data of adults. And in my lifetime as a researcher, we've added colors to this scheme. So back in the day, we had colors that started at 10% prevalence. We never got up to what is on here, which is sort of the reds and, the reds and burgundies. Those didn't exist. And so this condition is worsening, in the sense that we notice that obesity in our obesogenic environment is spreading around the country and certainly around the world. If we look at certain groups who may or may not have an increased prevalence, this data is also very common. This comes from VanHeest data, and what you'll see here is if we look at the data, whether in total or based on gender, you'll notice that there are race-related prevalence differences amongst the groups. Now, whether you're thinking about the previous slide or this one, I do want you to always remember that SES underplays some of this data. And so socioeconomic status is an important underlying factor when we think about prevalence types of data. We also know that obesity doesn't live alone, whether that be clinically or whether that be in a public health domain. And what we find are comorbid scenarios with obesity. Those things being that individuals who are overweight and or obese are at a higher risk of morbidity from a number of chronic conditions that you see on here. Higher body weights are also associated with increases in all-cause mortality. So obesity increases our risk for chronic disease. So if we think about it, a reduction then in our obese or our weight status should ultimately cause a reduction in that risk. There are other things that are not listed on here, but are certainly important for us to think about. One of those things is the complications that we may see in pregnancy in an individual who is overweight and or obese, especially if they're carrying any of these additional comorbidities. Additionally, if we think about individuals that are preparing for surgery, an individual who is overweight or obese may carry an increased risk. And oftentimes this becomes that really negative cycle. So take, for example, an individual who needs a hip replacement who's obese. And they cannot have a hip replacement until they lose some weight. How are we going to get them to lose weight so that we can get them to be able to have the hip replacement so that they can be more active? That's a really chicken and egg conundrum in how we manage that in terms of using physical activity as a method of treatment. Causes of obesity have been evaluated for many years. Most of us think that this is a pretty current kind of pursuit, but actually back in the 16, 17, and 1800s, individuals were trying to figure out what were the underlying causes of obesity. And there can be many, and a lot of debate and argument around what those causes may be. Obesity is complex. So if we think about the underlying causes, they can fall into any number of categories, but understand that when we think about the causes of obesity or the things that play a role, they play a role really on one or the other side. And that being either an energy intake or an energy expenditure side. Now, I'm not going to spend time today to get into each and every one of these, and we will spend the majority of our time thinking about the expenditure side. However, I want you to always remember that this is a complex interrelationship, and that if you do something to one side, it impacts the opposite side. The sort of classic illustration for energy expenditure is to think about it in what is known as total daily energy expenditure, or TEE. And this is made up of a number of things, that being our resting energy expenditure, thermic effect of feeding, and then our activity energy expenditure. If we think about these, what you'll note is that the resting energy expenditure is the largest amount of this particular total energy expenditure, and that's whether you're normal weight, underweight, and or overweight. The most manipulatable element is the top component. And the top component should be thought of in an interesting sort of two-part way. One is exercise energy expenditure, or the purposeful energy expenditure that you and I would do if we went out for a walk, etc. Things that many of you in this room are very good at prescribing. The other piece, however, that we often take a little bit for granted is this notion of non-exercise activity thermogenesis, or NEAT. And it's a small amount, but it can grow to a larger amount. Some of you are sitting in the back, and there's an advantage of sitting in the back before you present. You know who's the fidgeters and know who are not the fidgeters. And those of you who are the fidgeters tend to have a larger proponent of NEAT, which is fantastic. I don't have anyone here except for the folks that are running this show that are doing the standing. Usually when I give a talk on obesity, I have the obligatory people that are standing to prove to me that they're standers, not sitters. So when I start talking about NEAT, they're like, that's me. I'm a NEAT person. Right? I'm increasing my physical activity through standing versus sitting. But NEAT is a manipulable variable that I want you to think about as an exercise physiologist, because it is an important element, and we often disregard it. We often take physical activity as just that top component, exercise energy expenditure, that 1 hour, that 90 minutes, that whatever time, and we block it off as this sort of wonderful golden thing, and it is. But we don't talk about all the other choices that individuals may or may not make. If we go to this classic energy balance concept, Here what you'll see is this yellow individual that represents you or I or anyone else. And we, as I look at you, are all sort of these warehouses of energy. And that energy is divided up into energy that is either in your fat mass or your fat-free mass. And we can divide up your fat-free mass into sort of the bone component and the non-bone. And if we want to do different types of techniques, we can get even more specific about that. But for today's purposes, I want us to think about fat mass and fat-free mass. And if we think these elements, who we are at this given moment in time, is really the relationship between our energy intake and our energy expenditure, and any weight change relates to that. And so when we often discuss the notion of obesity or physical activity strategies around obesity, we don't spend a ton of time thinking about how our body composition may impact that. And sometimes we don't think about how physical activity then impacts that body composition, which then impacts how we manage energy. I'd also like to show you another sort of interesting idea, and that is that our body composition and changes in our body composition do actually impact our energy intake. And so this is some data from a study looking at normal weight and overweight individuals over a 12-week intervention. What they were looking at is what their energy intake is in a single meal and then in total daily energy expenditure. And so what you see here on the left in the top panel, which is a little fuzzy, is their ad libitum dinner calories. And on the bottom is their total daily energy intake in relation to fat-free mass. Now, for those of you who've been reading the obesity literature for years, adipose tissue is the central core of that research. And if we think about it, it's all adipocentric. And along came leptin, which reinforced our adipocentric concept. That leptin was the miracle thing, and it related to our fat status, and that related to our appetite. And so suddenly we disregarded the other elements in terms of this very complicated origin or control of our body weight. And I would argue with you to not disregard fat-free mass. In essence, fat-free mass in this is strongly, highly, significantly related to their dietary intake, whether that be in a single bout, a meal, or over the course of the day. If I were to plot fat mass, it has absolutely no relationship to what they consumed. Now, let's see if we can replicate this concept, because it is a little blasphemous in our adipocentric philosophy about obesity. So if you take a look at resting metabolic rate, and so this is now resting metabolic rate versus energy intake over the course of the day, what you find is a very similar, strong relationship between resting metabolic rate and the drive to eat, right? Appetite, energy intake. If we think about resting metabolic rate, we all know that fat-free mass is a primary determinant of resting metabolic rate. And that resting metabolic rate is the largest component of our daily energy intake. So it appears that our drive to consume calories is not purely driven by adipocytokines, but may also have some relationship to our physiologic demand that supports our fat-free mass. If looked at as an integrated scheme, as you see here, if you were to take a look at sort of what's on your left, it's our body composition and its impact on our drive to eat. What you'll see is that as fat-free mass is elevating, we see that that impacts resting metabolic rate, and it's causing us a drive to eat. If fat mass is involved in this, what you'll see is that it works its way through leptin. So as as fat mass increases, then leptin inhibition to eating actually decreases. Now, some of you may be thinking, oh no, my goal is to do resistance training, improve an overweight person's fat-free mass, and suddenly I'm going to make him this ravaging fool, hunting and scavenging for food. And one of the arguments is that it's not as simple as let's push this thing all to the left or all to the right. It's the notion that there's this strong interplay. And in fact, if you look, physical activity also impacts on the right side gut hormones. And those gut hormones interplay with appetite. And so the reason I'm showing you this is that when we try to derive a simple solution for this complex physiologic, psychosocial, and behavioral condition of overweight and obesity, it's often difficult to get a simple answer. And so we need to think about things in sort of a broad scenario. Now I want to take a completely left turn for a moment. I now want to have you think from this sort of physiological evaluation or endocrine area, which was my most comfortable place to be as a researcher. And when I started getting away from working with athletes and working with overweight individuals, I had to think differently. As I call it, I had to think above the Adam's apple. You know where I'm going with that. The notion that behavior is important, and how do we drive behavior? How do we integrate behavior? How do we integrate the behavioral piece and the physiology? Now, the previous speaker talked about this notion of behavior impacting physiology, and I still am a physiologist. Therefore, I think many of us are in search of those scientific behavioral physiologic reasons that behaviors work. I am sure that behaviors have some relationship to our endo system, and that those endo factors are going to play a role. And we're starting to see that's important. However, the messaging may also be extremely important, and we know that from the data. How many people in here know about this concept, physical literacy? Anyone heard of it? That's not right. Physical literacy. I can guarantee the people in this room are good. You're also physically literate. Much more than if we took a random sample outside of this room of people your age, gender, ethnicity, etc. Physical literacy is defined as the following. It is the motivation, confidence, physical competence, knowledge, and understanding to value and to take responsibility for engagement in physical activities. So this notion of physical literacy is extremely important. It is really what we're trying to get every human being to do, is to become more physically literate, much like what we're trying to do in other forms of literacy. It takes on behavioral components, cognitive components. It takes on motor development components, and obviously physical components. It is often thought of as something relating to PE. It is very common in our international colleagues' discussion around engaging in physical activity. The reason I'm bringing this up is that it underpins the value and the understanding of what you're trying to get individuals who are overweight and obese to do. And for them to understand and to think about things in a different way may enhance your success and their success. Now, if we think about physical activity, what we've seen and talked about is so many individuals are not engaging in our national recommendations. And we often think that there is nothing that we can do, or that this is such an uphill battle. We really don't know where to go. But I'd like to give you one tiny bit of encouragement. This is data from the National Health and Interview Survey that is related to the Healthy People 2020 goal around engaging at all. And so basically what we're looking at here is the number of individuals who engage in no leisure time physical activity at all, 0. You should be happy. That number's going down. And in fact, I mean, look where it was back in 2006, which isn't that long ago. The goal here is 32.6%. That was met back in about 2012 by both males and females and has stayed below. So people are moving. Now if we can just get them to move a little bit more, right? But they're hearing the message of movement is good, which is a positive thing for our industry and even more positive for the individuals involved. If we look at overweight and or obesity and recommendations, and there's a new set of recommendations by the Endocrine Society and others, but these should look pretty common to you. The notion of moderate and vigorous. So where do we sit when we think about moderate and vigorous physical activity? Well, as we know from NHANES data, physical activity in large-scale studies relates to body weight. So those who are engaging in moderate to vigorous physical activity tend to have lower BMIs. We do not see the same trend for low intensity. So there is some sort of threshold effect, which is why we're always working to get people to work up to moderate to vigorous. And that's some of that data that underpins that. So it implies that there's this sort of threshold. We need to be able to get to more moderate to vigorous forms of physical activity. Similarly, when we think about resistance and endurance, we often think about weight loss being an endurance physical activity phenomenon. Resistance may or may not be important. And for the most part, we see that, yes, certainly aerobic endurance type physical activity is critically important in an individual's ability to reduce their body weight. And we'll talk a little bit about how much in a minute. But remember, even though we may not see strong data supporting resistance physical activity alone as a predominant means for substantial weight loss, remember what that resistance training also does. It does two really important things. One, it impacts fat-free mass, and that by itself will impact those factors related to how we manage our energy status. But I would also argue that it impacts an individual's strength and muscular endurance capacity, which allows them to also think about engaging in NEAT. Will I take the stairs if I cannot? The answer is no. Will I stand for a 1-hour talk on obesity if I am not strong enough to manage that? The answer is no. Right? We're humans. We tend to go to our most efficient place, and that is seated or lying. That's where we're very efficient. I didn't say it was good for us. I said we're efficient there. You look at any mammal, they like to be in that environment. They like to be supine or sitting because it's efficient for them, whether it's a marine mammal or it is a land-based mammal. So again, thinking about how we encourage individuals, what kinds of things do we do, and how do we sell it, which is an important element. So let's talk briefly about what many of you in here already know and do. And one of the things that is difficult for an overweight person to hear is that our recommendation for you to lose weight is more than what we're going to tell everybody else to do just to be healthy. And they say, hey, thanks. It's been nice talking to you. Right? Whew. That's not an easy one to sell, but it's the truth. So we're looking at 60 to 90 minutes a day, which should get us about 2,000 calories of energy expenditure. That's one of our weight loss goals. So that's one of the interventions that we're talking about. Now, that is not going to come alone. That's going to come in concert with a hypocaloric diet. I'm not going to speak a lot about diet today. I don't play a dietitian, even on television. I have great colleagues who work in that field, and we work collaboratively with them, but realize that we're also asking these overweight people to reduce their calories substantially. 12 to 1,500 calories is often what is talked about for people under 250. 15 to 18 for those over 250, plus you want me to work out 90 minutes a day? No. It's a simple answer. It's different than thinking about a cancer patient. It's hard enough to get a cardiac rehab patient who had a heart attack or a bypass surgery to do it. Now you're telling this person who has not really had some major event to do it at the risk that you may benefit not having that heart attack later. Sometimes tough. If we really look at the National Weight Control Registry data, we're undershooting a little bit with this recommendation. Their recommendation is 2,500 to 2,800 calories, and that is an interesting sort of recommendation for folks in terms of their overall energy expenditure. We also see that this should be predominantly with aerobic type training, resistance training 2 times a week as it gets brought into the scenario. And intensity should work its way up to being moderate to vigorous. Certainly you don't always have the ability to start there. Most people use heart rate or can use heart rate. However, remember a lot of folks who are in these categories have comorbidities. Some of those comorbidities may be treated by drugs that impact our heart rate, and so heart rate cannot be used as our primary means to assess their intensity, and so we have to think about using things like a talk test or using RPE and training individuals. Individuals as young as kindergartners can actually get the concept of RPE down very well, and overweight kindergartens can actually really get the notion of what RPE is if you use smiley faces and beyond. And so I'm confident that adults also have that capacity. The other thing to remember is that when we're thinking about this exercise prescription, we really are thinking about that it does not any longer have to be in a singular bout. You can break those bouts up. Now, over time, we really would like to get that individual to be doing this longer singular bout if they're capable, and that's what we should be striving for. How do we do this? Well, there's a lot of therapeutic approaches. When I did my postdoc initially, I worked on the fen-phen study. Some of you recall that. I think Dr. Thompson's probably smiling more than anybody in the room. We also stopped that study for reasons that many of you may know. It did work. It had some side effects, but it totally worked on a lot of levels. The idea is that there are pharmacologic ways to manage this. There are surgical ways to manage this, and they work. People used to think that bariatric surgery was just the worst thing to possibly do. We need to think about the patient and what may be the most important things to that particular patient, but it certainly does work. However, most of us deal in the domain of this, behavior. How do we manage behavioral therapy? And so one of the things I'd like to know from you is if you're thinking about behavioral therapy, what do you think your patients are going to say when you ask them to do this? Give me a couple responses. You say, we're going to need to do exercise. And they say, my lower back hurts. What else? Don't have time. What else? Get too short of breath. You think they'd answer differently if you said that word? Or would they say the same thing? What?
My knees hurt.
My knees hurt. Okay? What's the paradigm difference? There is something. Enjoyment. For me to ask you how you feel about exercise, you can tell, oh, it's fun, it's this, right? Because you're nutty. you do this thing. This is who you are. They don't agree with that. But what happens is we forget about the value in understanding that we're trying to get individuals to do something that ends up being and can be fun. It can enrich your life, and you can certainly engage in it in certain ways that make it fun. There are all sorts of strategies for combating overweight and obesity in the country and around the world. I'm going to share a couple of things about these strategies, but we've thought about built environments. So how do we create our access or our barriers to physical activity? Certainly we know about the clinical approaches or community-based approaches. Worksite approaches have been going on for years. However, most worksite approaches have rather limited response or outcomes in terms of overweight. They tend to do better in terms of cardiorespiratory fitness. If we think about those community-based approaches, one of the things to realize is that's lifetime spanning. It's policy related. It's multidisciplinary. The reason I'm showing you this is these things can be undergirding to what you do with a one-on-one patient kind of relationship. You need to get them interacting in these outside kinds of things to undergird support, to enhance their knowledge, and to enhance the behavioral stability. If we think about behavioral approaches in their ability to create change, what we see if we do meta-analysis on behavioral approaches is that it's about a 3-kilogram change, which actually is a substantial change. It favors using behavioral strategies, which is why you as exercise physiologists are important in this scenario. But it's also a very time-consuming, very integrated kind of scenario. I'd like to show you this data. This is complicated. I only want you to look at the top graph, the blue line and the black line for now. And this is data from a long-term clinical trial in the diabetes world. You may have your speaker this afternoon talk about look ahead as well. But the look ahead study was really looking at an intensive type of intervention, that being personal contact, hypocaloric diet, as well as physical activity in the weight loss and also in diabetes management. And that was compared to sort of standard treatment, which was educational components for individuals and interaction with their primary care physician. And if you actually look at that top figure, over 8 years, what you find is weight loss in this sort of intensive approach remains substantially lower. Almost 5% reduction, which is as substantial health benefits. That's what we're looking for from their initial weight, maintained over 8 years. If you look at the bottom figure, that's their A1C. So if we were taking this from a diabetes perspective, that may not be the best outcomes. But we do see that it's useful for us as we think about how we may structure interventions on the behavioral side. They're intensive. They're relational. Individuals have to buy in. They have to find ways outside of purposeful to add activity. One place to do that is by engaging families. This literature base is growing, and I'm going to add one member of the family that is a sort of new interest of individuals who are studying obesity, and that is the animal member of your family, and the importance of using human-animal interaction. When I said animal, as I look around the room, I see faces smile. But I tell you, there's a difference in exercise and play. So if you walk your dog, that may be fun. Now the question is, does it work? And I'm showing you this one because it is an illustration of what often happens, but it has a little twist that I think is also important. So this was a study done in Scotland. It was asking individuals to take their pets out. It lasted 10 weeks, and they were asking them to engage in moderate to vigorous physical activity, and meet sort of the guidelines that we know quite well. The children in the family improved their percent of time spent in MVPA by about 8%. The non-children, the more mature individuals in the family, improved by about 8%, both of which were significantly non-significant. And suddenly people's response was, well, this is a bad idea. Now, I'm going to give you two positive pieces from this study. Number one, here's data from the animals, in case you were interested. On the left is the baseline, okay? Light to moderate is green, vigorous is yellow, and on the right, what you'll find, intervention and control. The follow-up, the dogs got healthier. Dogs got a lot healthier, okay? Significantly healthier. Why does that matter? Well, this was a 10-week study. So if you keep walking your dog, if you keep accruing that 8% improvement, number one, your dog's going to force you to go out. And number two, we may see in longer duration studies that there will actually be substantial improvements. It's important for us to think when we talk about lifestyle interventions, behavioral interventions, that there are a number of things we can add in. One is obviously ourselves, and adding ourselves into it. That means relationships are important. Individuals should self-monitor, whether that be their dietary intake, whether that be their energy expenditure or their time, their fit elements, or some people don't like the notion of monitoring weight, but individuals should be monitoring weight if they're overweight and or obese. If you look at the National Weight Control Registry, those individuals monitor their weight at least daily. And otherwise, they're unable to make fine-tuned adjustments. The other thing is the use of technology. Some of us are old school. We like papers and pencils. But technologies provide us feedback. They provide behavioral supports. They provide, in some cases, networks. So we're reaching out to social groups. So I can now go for walks with my sister who lives in Michigan and my other sister who lives in Indianapolis. And we walk 3 times a week together as sisters, which is a fun thing to do. And that's built-in technology. So how do we use technology as an advantage, as a strategy? So if we think about it, we need to remember that responses are going to be extremely individual. The variability around that behavioral 3-kilogram change in these interventions range in the first 6 months ranges anywhere from 0.7 kilograms to 8.5. So it's a very different business depending upon the physiology of the individual. Relationships are critical. Relationships are critical. The data supports those behavioral elements because you are creating a relationship with the individuals, which will increase adherence and compliance and ultimately the efficacy of the program. The other pieces, they're integrated. They take in the psychological aspect. They take in the physical domain, the endocrine, the cardiovascular, and those people work together in a very integrated way. I would also argue that it's not merely those people in the clinical setting, but those people outside the clinical setting that are important in this integrated approach. Now, I want to take a last couple of seconds. I know that many of you don't work with children or don't have the opportunity to work with children. Sadly enough, we're seeing that more and more children are now engaging in clinical programs for overweight and obesity. But we've had the opportunity to work for a number of years in this, and I just want to share you some data that applies to both children and adults, and also to give you some underpinning if you have individuals who are questioning these concepts. The CDC came out a couple of years ago with the notion of whole school, whole community, whole child models, which was a way for us to think about integrating all of the aspects in a young person's life into their ultimate ability to do two things. One, to be a healthy individual, so normal weight, but also to achieve academically. And so the CDC was interested in having these elements combined. We've taken this whole school approach for many, many years, and it started with my observations as a young researcher about how children play. And in essence, I could do the same exact thing and have pictures of adults, as you well know. Boys play a certain way, whether they're normal weight or overweight. They play relatively intensely together, more intensely if you're normal weight boys. Sorry, ladies, I know we've come a long way, but this is how we play. We've played this way since the beginning of time. We're getting a little better. I'm not suggesting we aren't. But we play a little less intensely. We play on the periphery of the boys. And overweight and obese children play like this. And so the concept that we tried to develop was, how do we get overweight children to engage in play, in neat? Right? How do we get them to be both purposeful and non-purposeful? And so we designed a program called Paw Pals, which stood for Physical Activity as a Lifetime Skill, instead of something you learn as an adult. The idea is that children will engage with adults in an adult monitored and mentored program. All adults had to play. They were able to control the program, so they were able to do the free play aspects. It is based on a behavioral theory concept known as the spinner theory, and this is data that comes from organizational behavior, but it's the notion that if you take a group of humans, whether they're children or adults, and you put a lot of structure on him or her or that group, their spontaneity goes down and their creativity goes down and their success goes down. If you let off that structure so that it's unstructured to the point where no one gets hurt, what you'll find is that they become extremely creative and they extremely bought in and ultimately successful. And so if you come to Paw Pals, basically physical educators in the room, you would be quite upset if you kind of came from that area. It is chaos, and it's designed to be chaos. It's child-run chaos. Actually, what it is, for those of us who are kind of more mature in the room, it's what our backyards used to be like after school. That's what it's like, with no parents telling us, line up, play game A or B, wait, hold on, take your heart rate. None of that. Right? It's what our backyards used to be like. The question is, would it work? We weren't sure. We've done quite a bit of research now on this over the years. And what we found, if you take a look at this first scenario, is that this is pre-post, boys on the left, girls on your right, post in the yellow, pre in the green. What you'll find in the 1 hour before school program, the individuals were able to almost double in the boys and about a third addition in the girls after 10 weeks of their voluntary movement. So they were changing substantially. If you were to do the math out and calculate how many calories they burned in one academic year, they could have, in theory, lost 4 pounds. And these were children who were all considered overweight and or obese. And so these aren't normal weight kids. That's great. Not much, though. That's basically maybe an Oreo cookie a day, which if you've met a child that age, 3rd, 4th grade, they'll compensate quite effectively. But what happens? Do they gain physical literacy? The answer is yes. Look what happens at recess. They go from standing around to highly engaged. They increase their neat and or their purposeful activity. In fact, they became the leaders in the playground because they knew how to play. When they went home, same thing. They spontaneously were more active at home in their free time. They engaged in more physical activity. So the answer would be yes. Our belief is yes. If we integrate play, if we integrate behavioral constraints with physiologically appropriate exercise prescription, children and adults can be successful, but it takes an extraordinary amount of work. Weight loss, as we well know, improves disease status. I would argue for you to consider and can keep considering how you can build relational aspects, whether that be in your one-on-one interaction or by using programming outside of your sole one-on-one interaction. And I would also challenge you to always think about the paradigm of what you're talking about. Is it fun? And if it's not, adherence will go down. And with that, enjoy your day, stand up. If you have questions, I'm happy to listen. Thank you.
Questions? I have a comment and a question.
Sure.
I love the concept of play. And way back in the old days, the FITT acronym was FITTE.
Yes, it was.
For enjoyment.
Yes, it was.
And I was very upset when they removed the E. And I still teach it to my students, and I'm just wondering if we could convert the P
to an E.
P to progression and play.
Absolutely.
I think that would be a really nice thing.
Thank you.
So,
thank you.
Thank you for that. My question is on the endocrine stuff that
Sure.
you said in the beginning. So you mentioned leptin as one of the key endocrine factors
Sure.
for fat mass. And I'm wondering, are there other endocrine factors that have been discovered for fat-free mass?
There are a number of endocrine factors that play a role that are not solely adipocytokines. We think about insulin as an endocrine factor, which would be sort of my number one fat-free mass factor that we think of. We think about the insulin-like growth factors associated with that as well. So yeah, there are, but leptin is not the only adipocytokine that we're thinking about, but I think it became sort of the hottest, most interesting because it was something that we could measure, and everyone went back and measured. But yeah, I often tend to think about the insulin side and its sort of cofactors as a fat-free mass, one that's pretty common. Yeah. Other questions? Yeah.
I was thinking about what you said at the end about women and girls engaging in play or activity less. So in my experience, I have not worked with children, but more so adult women, and I do find in my own experience, it's less common, they're less willing to do it, and or it's just not familiar to them. So in your opinion, what do you recommend to get more women and girls engaging in play or activity?
The great question. And it's the question around sort of a gender effect, men versus women. One of the things about women, and I often get a lot of pushback on this, but we are really social creatures, right? We shop together. Think about middle school girls. They don't even go to the restroom alone. And so, and that's a woman saying that, okay? So it's that notion of how do we create communities of activity that women can engage in. People have talked about the notion of female-only gyms, and is that a good thing? And you know, I don't know if I'm going to buy into that as the way to approach it, but creating social networks. One of the things to realize is that if you can have women interact with women, whether it be locally, so in real life, or it be through technology, that they do this together, that is one way to get women more engaged. The other ways that a colleague of mine joked around, and she said she'd try it, and she has, and that is the notion of saying, we're going to go to happy hour, but before we go, ladies, we're going to go for a walk. So how do we tie it into some things that we might naturally do together? Get it to be purposeful, tied to something social, and that will sometimes overcome those aspects.
Other questions?
Someone has like a certain amount of like macronutrients that they should get, maybe around like 3,000 calories. I feel like a lot of people usually feel like if they exercise for a certain amount, that they say like, oh, well, I can eat this back, or you know, I can eat more than I usually would because of exercise. you think that with exercise or a more active day, that someone can actually eat more than, say, 3,000 calories, or should it be still eating within 3,000 calories? Do you think that's where the obesity might kind of rise?
Repeat the question.
Yeah. It's the question is, excuse me, is the concept of if I go and work out, can I, you know, eat other kinds of things or higher kinds of calories? There's a lot of discussion around how precisely we manage our energy. And so one of the questions would be is if you're constantly saying, I'm going to work out, therefore I can eat extra. Unless you're pretty capable of doing that sort of mathematics gyration around what that extra is, if you're eating extra than what you're expending over time, you'll gain weight. But now there's new literature about is a calorie, you know, but we still, I think, believe that, you know, if you're going to overeat to some degree in terms of calories across a window of time, the question is, what's that window of time? Some people have thought in the past it was a really short window of time, and I think you have to think about it may not be as short a window of time, but it's certainly, if you eat more than you burn, weight goes up. That's just the math of it, sadly. Now, one of the things that happens, especially when we're talking about overweight or obese individuals, we say that, and that creates a level of rigidity for them that is not sustainable as they get moving along. And so if you go ahead and have a piece of birthday cake at your child's birthday, that's an important thing to engage in that. But then you got to figure out how you're going to manage that later on. So it's being able to be a human being within this sort of balance scenario. The one connection that I would argue with is that, and we've played around with this with athletes, what we find is the relationship to eating and physical activity is important over the course of the day. We often measure it in 24-hour windows, right? Because that's a simple way to measure it. But if we actually see what's going on hormonally, both with intake and with an expenditure, we see that oscillating over the course of a day. And so how do you marry those things together? In athletes, what often they will do is they will backload their calories. Overweight people can tend to do this too, where they will not eat breakfast, not eat much for lunch, and gorge this huge meal in one setting. What we find is that the hormonal environment in that tends to improve storage. Right? So that's maybe not the way you should do this. You should think about it in how you balance your ins and outs over the course of the day. Is that the answer? Okay.
I have an online question, or a couple.
Sure. Yeah, Susan Bennett. How do you typically address the issue poor body image with increasing movement? Many individuals are embarrassed to move more because of body habits. It's a great question. One of the ways that we've addressed that is to have individuals choose to come up with modalities they can do in private settings. So we've used home-based intervention for middle school age girls, or have them be physically active. And middle school age girls are probably one of the groups that has the largest body image issues. And so we've had them start in home-based or home arena, meaning in their own neighborhood, and from that have built a better sense of who they are in terms of being physically capable. The idea of really getting people to think I'm physically capable, which improves, in essence, is improving their physical literacy, will help address this. But doing it in more private settings, which again kind of gets to the women thing, would a female, overweight female go to what place to be physically active? Would they join a gym? Maybe, maybe not. Right? So it's thinking about that, and that's where some of the ideas of women-only gyms have come into vogue as well. Yeah. question.
Go ahead, Jackie.
Oh, sure. So you talked about how technology might be a good way to have people start self-monitoring. I just picked up a book called Unplugged, and the importance of how we become dependent on technology and now that when you talked about play, that really becomes a structure. Even for myself, I want to hit my steps because this thing is telling me to. Not so much I want to hit my steps because of my health. And I find that even with my personal training clients, like it becomes more of a dependence on the technology rather than I'm doing this for my enjoyment. What are your thoughts on like the interplay between the play and the technology aspect?
The question is around technology and play and fun. It is a really tricky kind of question. One of the things that I suggest is not necessarily using that smartwatch on your arm as this automatic biofeedback thing that we've now become, but to use it as a data collection device that stores it. In other words, I'm storing it in an electronic sort of way. I'm not necessarily using that as the chronic behavioral piece. There is data to suggest that that is an important behavioral prompt for us to get up. And so it's sort of that slippery slope. I guess maybe I'm old enough to say this, that there's a certain generation that tends to be much more attuned to the every bing and bong of those, also being an educator. I hate those watches because they're fooling you, right? You can tell them put their phone away, but they're like checking their watch. And it's that notion that you're so tied. One of the advantages I really like about that technology is it creates a community of practice for people being active. So there may be an advantage to say I'm going to use my smartwatch so I can work out with or I can play with a friend of mine as opposed to using it as a prompt that's basically someone standing over your shoulder, the little dude going work out, work out, work out, walk, walk. Right? So it's a very different approach. One of the things we're working on right now is using an a screen gaming device on a bicycle as a way to get overweight middle school children to engage more intensely as well as more frequently in physical activity. And, it's working. So it's a slippery slope. Like, you can't completely put technology away, but how do you integrate it? If it becomes the person with the whip, then that's probably not the healthiest way to use it.
I apologize. I have to bring this session to a close, but you can obviously, there are other questions you can interact with. We just want to thank you very much for an excellent talk.
Thank you.